It gives me great pleasure to introduce Dr. Sujit Choudhary, the next speaker on the topic of minimally invasive approach to pediatric solid tumors. Sujit actually doesn't need an introduction to this audience. He is the clinical director of the Apollo Institute of Pediatric Sciences in New Delhi. Very well published. He is on the executive council of the Journal of Pediatric Urology. He is a reviewer for two prestigious journals, the Journal of Urology and the British Journal of Urology International. He is a senior examiner for the RCS, and as a pioneer in robotic surgery in children, he is the director of the Apollo Intuitive Robotic Pediatric Urology Program. Sujit.
Thank you, sir. Good afternoon, ladies and gentlemen. Can you move it? Okay. In the next 15 minutes, I'll quickly go through a few slides to show you my thoughts on this topic, which is evolving and not yet fully stabilized. When I was training in pediatric surgery, way back in the 80s, late 80s, the French team was already standardizing laparoscopic and retroperitoneoscopic nephrectomy, and they published their first series when I was in England at the time, Jeff Vala's group, and they already showed that it was safe in kids. And in 1996, the National Cancer Institute awarded large funding to pediatric oncology group to examine the feasibility of MIS in pediatric solid tumors. Sadly, it got withdrawn within 2 years of the funding coming. And the reasons cited were the reasons that we know of today. Preconceived surgical bias against tumors, laparoscopic surgical expertise and experience was not there, which has seriously changed today, and communication between oncologist and surgeon was not found to be satisfactory. What happened next? Okay. The reason for surgeons who were masters in surgical oncology not switching on to laparoscopy at that time and even in current times are listed, and everybody is worried whether the eventual outcome of tumor surgery will get altered and increased risk to life. So for my younger colleagues, I want you to know that it's a path which one has to take very slowly and steadily, but it is a path which is surely going to build. What is happening in the US today, those numbers shown there are the total numbers of neuroblastoma and Wilms tumor getting operated in the whole continent. And as you can see, a very small number gets done by the MIS route, and the proportion which gets done by the robotic route is shown there. And you will see strangely that Wilms tumor gets more often done robotic than neuroblastoma, and the conversion rate in the robotic approach is slightly different. What is happening in MIS for pediatric solid tumors in 2018 as we talk today? There is lack of evidence in terms of better outcome in favor of MIS. However, is it actually possible to have a better outcome by the MIS approach? The answer is no, it's common sense, because you can't improve on the already existing outcome measures. So we have to discuss actually what is the outcome measure that we are looking at. Can we reduce blood transfusion? Can we reduce ICU stay? Can we reduce pain? Can we reduce the incidence of radiotherapy, recurrence, etc.? As of date, there is no RCT comparing lap versus open pediatric solid tumors, which means that in standard clinical practice outside institutions or those in the institution without special approvals, it can't be done. However, there is no RCT comparing pediatric versus laparoscopic open cholecystectomy. How many of you today will still do an open cholecystectomy? So the fact of the matter is that much of what we do is based on extension from the evidence derived in adult surgical practice. So what is the evidence in the adult surgical practice? Do we have RCTs in adult surgical practice around renal tumors, adrenal tumors? Look at the numbers and look at the papers. There's enormous evidence. There is enormous evidence of controlled clinical trials looking at all aspects of tumor surgery, and all answers there for you to see that comparable outcomes with respect to 5-year tumor-free survival, significantly shorter stay, significantly less blood loss, and no difference in the outcome. So there is rationale in chasing this path of MIS for solid tumor. How is the horizon on tumor surgery in US changing after the robotic system has arrived? You can see that whereas the open surgery has almost stayed steady after a certain drop when the minimal invasive surgery technique came up, the laparoscopic technique is steadily going down and the robotic is picking up. So when we looked at the current world experience of MIS in solid tumors, it's very small, it's not extensive. This series published by Yves Hillary's group from Melbourne, who's actually a part of the original French team who has moved to Melbourne, they reported 18 cases and a total of 86 cases in literature done on Wilms tumor with comparable outcomes, although the follow-up period is only 20 months. Our own journey of MIS is not very long. We started in 2005 and have gradually graduated. But to develop and build any new surgical approach, you need caseload. And I don't work in a public institution. I work in a relatively small center where the numbers are limited. But we do about 600 cases a year, of which about 150, 200 are daycare, the rest 350, 400 are major. And you can see that the tumor numbers are not big. They vary between 20 to 30 cases a year. So lap nephrectomy and robotic nephrectomy, if you look at the different approaches, that's what I have shown you, and shown you to show that the polar pathology, we have used robotic more often than laparoscopic. For the non-functioning kidney, we are very conservative in removing the non-functioning kidney, although Dr. Rao said this morning that every non-functioning kidney should be removed. We don't believe in that, and when it's done, it's usually laparoscopic. And Wilms tumor, currently we use the robotic approach. In the whole pediatric practice in general, the tumors are varied, and there isn't much approach for standardizing this technique because the tumors could be rising in any part of the body where you can't really use the MIS technique. Liver, sometimes the location of the lesion can be such that you can use the MIS approach, but largely it condenses to renal tumors and adrenal tumors. Our own path with Wilms tumor was that we published the first experience with the role of angioembolization as a case report. Then in my work in PGI in the first 5-6 years, we looked at 25 cases prospectively, managed on modified SIOP protocol, and showed that although working in India, we were matching the result outcomes in the Western world for T1 tumors. And because we can match the results of T1 tumors, we then went on to do a nephron-saving surgery for a child with Beckwith-Whitman syndrome, WAGR syndrome. Coming back to how we started with this whole program in our own center, way back in 2008, we met an interesting case which was explored with a diagnosis of TB abdomen, which to our great horror came out to be a small bowel tumor. He had an extracorporeal resection and anastomosis, and his 13 years follow-up without any problem. That led us to believe that we could start doing tumors laparoscopically. This was 2008. A child with a functioning adrenal tumor who had a lap adrenalectomy, a small-sized tumor, ideal for a MIS approach, and many of you have reported cases with this kind of case. That was way back in 2008. As far as the Wilms tumor is concerned, those are the 3 conclusions that have come out of the literature that exists currently. But in 2009, we met our first case where we thought that we could use the MIS approach. This was a bilateral case with one size large tumor, not responding to chemotherapy, and had an open right nephrectomy. The contralateral side had a tumor which had responded to chemotherapy but still persisted and had a laparoscopic wedge resection and remains on follow-up. The second case in 2009 we saw was a very interesting one, a 6 centimeter sized lesion located in the hilar region, which was highly vascular, not amenable to any needle biopsy. So we decided to do a laparoscopic exploration, and at frozen section, we were horrified to find that it was a renal cell carcinoma. So this child had a laparoscopic nephrouretrectomy and remained well for 5 years on follow-up. Years rolled by, we didn't see many cases which we thought were appropriate for doing a minimally invasive approach. But from 14 onwards, we got the robotic system. And since then, whenever we have found a small tumor or a tumor which has responded to chemotherapy, then we have used the robotic approach for it. And currently, we have completed about 8 or 9 cases. So what are the typical lesions you can do robotic? If you had a small lesion which was less than 6 centimeter, located to one side, stage 1 tumor typically, this kind of a lesion today would get done by the MIS route in our center without any trouble, and we will have no second thoughts about it. I've got the videos, but I'm not playing it for shortage of time. If anyone is interested, we can see later. The second scenario is a tumor like this, which has had 2 or 3 or 4 cycles of chemotherapy and then has responded to become less than 6 centimeter size, which can be addressed by the MIS route very effectively without compromising on the outcome. There's a small video there to show you how the specimen comes out. Eventually, just to show you that the incision through which it comes out is below and is relatively very small incision, and the specimen always has to be taken out through a bag. Now, some of my colleagues in this talk given somewhere else said that, oh, we don't see small tumors, we only see very big tumors. But with the SIO protocol, almost 60 to 70% of the tumors will have that kind of response. If the pre-op tumor is showing you a very large tumor, 60% of them will reduce to a very sizable tumor to be addressed by the MIS route if you were patient and not rushing into surgery. That was a video to show that tumor. Later on, I can show it if necessary. This is a kid. This is another child who had a relatively large-sized tumor, more than 6 centimeter. We attempted this child and we finished the surgery, but when it came to extracting the tumor, we had to make a relatively large fan steel incision. And this is the kid on day 1. Nephron sparing surgery, it's an excellent approach. This is a kid with WAGR who had a tumor on the right side, a hilar tumor. The contralateral kidney is at risk for tumor in 10% patients. And so this was a case for a nephron sparing surgery. We did a 3D CD reconstruction. We were lucky to have vascular supply, which allowed a hemi nephrectomy to be done. And that was done by the robotic technique. That is the histopathology to show you no residual tumor at the end of hemi nephrectomy. Post-op course was straightforward. They increased urine leak for a few days. That is the Doppler to show you adequate blood supply in the lower pole. This is the publication that we did. And this is the last case which showed that this was a high-risk malignant FEO where we consciously decided not to give chemotherapy because the resection margins were clear, but unfortunately 9 months later, the kid came back with recurrence in the spine with compressive myelopathy. So that is the total numbers that we have done in the last 10 years, 21 cases without adversely affecting our own post-operative results of tumor surgery. That is the list of patients who have had surgery for Wilms tumor, laparoscopic and robotic. That is how it compares to the world literature published. So as you can see, the numbers published from the centers, even in US, excepting 1 or 2 centers, are really in single digits. So in conclusion, PSYOP recommendation on Wilms tumor does confirm a role for MIS in pediatric solid tumors. Robotic surgery will offer deeper penetration of MIS for solid tumors in children, more so where nephron sparing surgery is necessary. Our experience in MIS in solid tumors is evolving. There is no Indian published data yet, other than our solitary report on robotic nephron sparing surgery in renal tumor. And the most important is that we have isolated surgeons with excellent laparoscopic skill, far exceeding in many other units where the numbers are huge. So unless there is some collaborative work, we are not going to be able to bring out scientific evidence in children, either for or against MIS for solid tumors in children, which is what the Cochrane database has recommended. Thank you for the privilege of the stage, and if there are any questions, I'm happy to answer.
Thank you. Thank you very much, Sujit. An impressive experience on minimally invasive surgery for solid tumors. I invite questions from the audience. I just thought I'll take off on a couple of things. One is, In renal cell carcinoma, one of the things that we use is an intraoperative ultrasound to detect margins. When you're doing that for Wilms, do you do that? And question number 2, how good is your node sampling when you're doing a robotic nephrectomy or even a partial nephrectomy for Wilms? Because that node sampling is pretty important. It has to be comprehensive.
So, sir, actually of the 9 cases that I showed, in one kid, which is the post-chemotherapy kid, which was clearly a very extensive tumor, that whole area was very badly plastered.
Okay.
And I thought that that particular kid, maybe in open, would have got some better node sampling if it was done open. However, no case enters the OT without going through the tumor board. Most of them are already slated for chemo and radiotherapy, so that even if your lymph node was positive, they were already anyway going to get the radiotherapy because the extrarenal spread.
Well, first of all, I must commend you because COP started off with lab tumor removals, and they kind of promised that they would come out with a big trial. I don't know what happened, and they soon made a comment saying that they would wait for other people to do it. Probably they didn't have many people to do laparoscopic to be offered. Now, whenever a new thing comes up, as you very rightly commented, there are a lot of hang-ups. We have been doing laparoscopic tumor removal for the last few years, and I presented in your meeting also. Now, the first series of 24 cases was a few years ago, in which a constellation of tumors were done. Mostly they were Wilms tumors. And after chemo and radio, the volume had reduced to about 25-30 ml. Now, in our country, we do see really large tumors, as you showed one of the slides also. We very large tumors. So when I decided to go hang on into a laparoscopic surgery, when the tumor came, I said I will do that also. It's quite easy. Dissection is possible. There would be few cases where it will be stuck to the diaphragm and sometimes fixed to the psoas muscles. Now, one of the hang-ups again was that when you remove the tumor like this, if it's the large tumor, you have to give a phalansteal incision, obviously, and you remove it. By that time, the pneumo has gone, and the access to the lymph node area bed would be difficult unless you really do it that way. So what I did was, after removing the tumor, I gave a lumbotomy incision, and I was able to retrieve the tumor from there. You could see very clearly the entire tumor bed. And this was the reason why the COP and others who were not actually doing it were very hesitant in saying that how would you access lymph nodes? You can access lymph nodes if your incision is there. So not only the tumor bed is where you're removing the tumor, so that there is no spill into a far site like a phalansteal area. You can do lymph node sampling all over the place, wherever you want to do it. And therefore, back to what COP is waiting for people like you and me or others to publish their data so that they can see whether if there is a worthwhile, they would have it in one of their arms of COP trial. So I would commend that well. Those who can do it, it is quite easy actually, especially those who are into laparoscopic in a very big way can actually do it well.
Thank you, sir. Just 2 comments to your questions that you have raised. You must have seen that after having removed 2 laparoscopic tumors between 2009 and 2013, for 3 years there's complete silence, and I did not attempt a single case, although there were nearly 40 tumors done between that 4-year period. And the reason was that we didn't want to land in a situation where we ended up with an unsatisfactory outcome. So I think it's very important to get the right case for this approach, because if we're putting the wrong kind of case for this approach, clearly this brilliant technique forward will have an aborted future. Second is that I don't think the answer to this question is going to come out of the European world, because in the European world the numbers are concentrated in centers where they do not have that level of laparoscopic skill in many units. And our numbers are much bigger here, although I'm in a private sector, we see much less tumor than the government sector. But I think it's a duty on IAPS to set up collaboration between 3 or 4 or 5 or 6 units, and maybe we can bring out some collaborative data which is meaningful. Thank you. Thank you very much, sir.
One final comment from Kanishka, and then we wind up the session.
It's a question of semantics. You would call it just a nephrectomy or a partial nephrectomy, not radical, is it? Isn't it? Or would
No,
you still
Kanishka,
say
there are beautiful
radical?
videos showing that you don't compromise with the surgery at all. You take the peritoneum, you take the retroperitoneal fat, you take the adrenal if you think it's an upper pole tumor. There's no compromise on it at all. Thank you very much.
I request chairpersons to felicitate Dr. Sujit at the momento.